Good evening, everyone. Am I audible and visible to all of you guys? Yes. Am I audible and visible? Thank you. Thank you. Thank you. So guys, welcome to the session. In this session, we are going to discuss about the high-yield topics of an obstetrics and gynecology. So we'll be discussing some clinical cases, and followed by that, we'll go into the deep discussion of the following chapters, and we'll try to integrate all these topics with the other topics of OB-GYN. Okay, so you can be interactive enough, answer in the comment section, and meanwhile, if you have any doubts, keep asking. I'll try to clear all the doubts here only. Okay, let's begin without any further delay. Let's begin. Okay, now let's start with the first question. A 32-year-old pregnant woman at 32 weeks of gestation. A 32-year-old pregnant lady at 32 weeks of gestation presents with a painless vaginal bleeding. She's presenting with a painless vaginal bleeding. After the session, I'll share the PDF. Okay, you guys will get the PDF after the session. So let's focus on the session. A lady presenting to you, she's a 32 weeks pregnant lady with the complaints of a painless vaginal bleeding. She denies any abdominal pain. That means there is no abdominal pain. The bleeding is painless. Her vitals are stable. The ultrasound reveals a low-lying placenta partially covering the internal os. What is the most appropriate next step in the management? What is the most appropriate next step in the management? Okay, comment down your answers. I'm seeing a couple of answers here. Okay, so let's discuss the chapter. Let's discuss this topic and then get back to the questions. I already got your answers. So it's a diagnosis of a placenta previa. What is your diagnosis, guys? Placenta previa. Your diagnosis is placenta previa. So what exactly is placenta previa? Before that, the period of gestation, a lady is a 32 weeks pregnant. That means it's in a case of antepartum hemorrhage. It's a case of a antepartum hemorrhage. Now, what exactly is antepartum hemorrhage? So antepartum hemorrhage is any bleeding from the genital tract after 28 weeks onwards. The bleeding is after 28 weeks onwards till the time of delivery. 28 weeks onwards till the delivery. That's going to be your antepartum hemorrhage. That's going to be your antepartum hemorrhage. Okay, now let's discuss about the first diagnosis. That's going to be placenta previa. Now, what are the different causes of this antepartum hemorrhage? It can be placenta previa, it can be vasa previa, or it can be a abruptio placentae, or it can be a abruptio placentae. Okay, now what exactly is placenta previa? It means when the placenta, this placenta previa means when the placenta is implanted. When the placenta is implanted completely or partially, it's implanted completely or partially over the lower segment. Over the lower segment. Okay, so what exactly is placenta previa? Placenta previa is when the placenta is implanted either completely or the partially over the lower uterine segment, Okay, now depending upon the degree of extension of this placenta, depending upon the different locations of this placenta, it can be of a different types. It can be a type 1 placenta previa, it can be a type 2 placenta previa, it can be type 3 placenta previa, or it can be type 4 placenta previa. So depending upon the extension, it can be of 4 types: type 1, type 2, type 3, type 4. Okay, what exactly is type 1 placenta previa? When the placenta, type 1 is when the placenta is in the lower segment. When the placenta is in the lower segment but not reaching up to os. but not reaching up to os. This classification, that's type 1, type 2, type 3 and type 4, it's called as Brownie's classification, and it's an old classification. The NIV classification says that either the placenta is in the lower segment, low-lying placenta. What exactly is the low-lying placenta? Sir, it's a 2 centimeters away from the os. It's 2 centimeters away from os. Either it's partial or either it's complete. Okay, but if you have a lateral, marginal, incomplete or central, that is a Brownie's classification. Now sir, do we have to remember these things? No, these things will put on the base of the question. Okay, but what exactly they will ask? You have to remember the management of a placenta previa. What exactly they will ask? Management of a placenta previa. And management of a placenta previa will change after every weeks. For example, if the patient is preterm, the management is entirely different. If a patient is in the term pregnancy, the management is entirely different. So all the questions that will be solving related to the placenta previa, you have to check whether the patient is in preterm, whether the patient is in term pregnancy, what are the complaints, is a baby having any distress, is mother stable or unstable, because every point of time the answer is going to change. Okay, the answer is going to change. So what is the type 2? It's marginal placenta previa. What's that? The placental edge. So that means placental edge reaches the internal os. The placental edge reaches the internal os. The placental edge reaches the internal os. Incomplete or partial placenta previa, that means placenta covers the internal os. The placenta covers the internal os when closed, but not when fully dilated. But not when fully dilated. So placenta cover the internal os only when the os is closed, but when the os is open, when the os is dilated, it does not cover the os. And the type 4, that is going to be placenta, central placenta previa. That means when the placenta covers the internal os. When the placenta covers the internal os, even when fully dilated. Even when fully dilated. Is that clear to everyone? Is that clear to everyone? So what exactly are the 4 types? We have the lateral, marginal, incomplete or central. This classification is called as the Brownie's classification, and as per the NIV classification, we have either low-lying placenta. So what exactly is the low-lying placenta? Low-lying placenta means the placenta which is away 2 centimeters from the internal os. Either we have partial or the complete. Okay, now the presentation of a patient. What are the clinical features of the patient coming with the painless vaginal bleeding? That's placenta previa. The first clinical feature will be the patient is going to have a painless bleeding. The first feature is patient is having painless bleeding. Okay, after that the uterus will be, on examination guys, uterus will be soft. Uterus will be soft and non-tender. The uterus will be soft and non-tender, and the size of uterus will be equal to the period of amenorrhea. So you have a patient coming to you with a painless vaginal bleeding, soft uterus, non-tender, the size of a uterus corresponding to the period of amenorrhea. Your diagnosis is, comment down the section, your diagnosis is placenta previa. Your diagnosis is placenta previa. Your diagnosis is placenta previa. Is that clear? Is that clear? Your diagnosis is placenta previa. Clear to all of you guys? Yes? Now next part. After you diagnose this placenta previa, what next? After you diagnose that this is the case of placenta previa, either there will be 2 scenarios. Either the period of gestation, if it is less than 37 weeks, either it is less than 37 weeks, or either it's a term pregnancy, it's more than 37 weeks. So there will be 2 scenarios, my dear students. So the first one will be either the patient will have less than 37 weeks pregnancy, or the patient will have more than 37 weeks. If a patient is more than 37 weeks, painless vaginal bleeding, soft uterus, non-tender, case of a placenta previa, your answer is going to be 1. That's going to be cesarean section. What is your answer, bacho? What's your answer? So the answer is going to be cesarean section. So any case of placenta previa at 37 weeks, any case of placenta previa at 37 weeks, your answer is going to be cesarean section. Okay. And if a patient is less than 37 weeks, if a patient is less than 37 weeks, your answer is going to be expectant management. Your answer is going to be expectant management. You will manage the patient conservatively. Okay, very good. Now what exactly is expectant management? You have to continue the pregnancy. What is the meaning? You have to continue the pregnancy. You have to continue the pregnancy, okay, without risk. You have to continue the pregnancy without risk. You have to continue the pregnancy without risk. So what exactly are the key features in this expectant management? First thing is going to be the patient is hemodynamically stable. The patient should be hemodynamically stable. Okay. Second, there should be no active bleeding. There should be no active bleeding, or there should be no fetal distress. There should be no fetal distress or no active bleeding. Then we follow a regime. What is the name of the regime? We follow the regime. What is the name of the regime? The name of the regime, very good. The answer is going to be, so the name of the regime is McAfee-Johnson regime. The name of the regime is McAfee-Johnson regime. In McAfee-Johnson regime, the first part is going to be you admit the patient. The first part is going to be, sir, you admit the patient. Second, you arrange the blood. You admit the patient, you arrange the blood. Okay. Third one is going to be, if Rh negative, give anti-D. If Rh negative, give anti-D, and give steroids for the fetal lung maturity. And give steroids for fetal lung maturity. Give steroids for fetal lung maturity. Okay, give steroids for fetal lung maturity. Okay, so what are the steroids we give, bacho? What are the steroids, guys? Tell me. The steroids that we give is betamethasone and dexamethasone. The steroids that we give is betamethasone and dexamethasone. Okay, and this betamethasone and dexamethasone, you already remember B2D4. How many doses of betamethasone? 2 doses. How many doses of dexamethasone? 4 doses. 12, 12, and the dexa 6, 6, 6, and 6. Okay, now sir, one more question that they can ask. Let's integrate a bit more. Now can you tell me how exactly we will confirm the fetal lung maturity? Very good. Can you tell me how exactly we will confirm the fetal lung maturity in a patient? Yes, the 100% confirmatory test for the fetal lung maturity. We have a different test. Yes, write down in the comment section. We can check the lecithin sphingomyelin ratio. Very good. We can check the phosphatidylcholine. Very good. And we can check the phosphatidylglycerol, and we can check the phosphatidylglycerol. So best test to confirm the lung maturity, again an important question, best test to check the confirmation of a fetal lung maturity, you check for phosphatidylglycerol in amniotic fluid. You check the phosphatidylglycerol in amniotic fluid. Okay, you also check lecithin sphingomyelin ratio, LS ratio, very good. You also check phosphatidylcholine, but this phosphatidylcholine is also found in the fetal serum, maternal serum and all. So better is to check phosphatidylglycerol in amniotic fluid. Okay, your one PYQ was asked the last exams. What will indicate a neural tube defect? Presence of which substance or presence of which component will give us an idea of a neural tube defect? What you will check in amniotic fluid that indicates a neural tube defect? What you are going to check in amniotic fluid that will confirm a neural tube defect? Yes? Anyone? In the comment section. Yes, the answer is going to be acetylcholinesterase. The answer is going to be acetylcholinesterase. I'm writing here over the top, acetylcholinesterase in amniotic fluid. AF is amniotic fluid. That's NTD, neural tube defect. That's acetylcholinesterase. That tells you about a neural tube defect. Is that clear to everyone? Yes. So a patient coming to you, painless vaginal bleeding, more than 37 weeks, term pregnancy, your answer is going to be cesarean section. A patient less than 37 weeks, you're going with the expectant management. If in less than 37 weeks, they mention the option of McFay-Johnson regime, Mark McFay-Johnson regime. Sir, what exactly is the McFay-Johnson regime? So we admit the patient, we arrange the blood, we admit the patient, we arrange the blood. Sir, if it's Rh negative, I will give anti-D. And I will give the steroids for the fetal lung maturity. I'll give the steroids for the fetal lung maturity. What are the steroids I'm giving? I'm giving betamethasone and dexamethasone. 2 doses of betamethasone, 4 doses of dexamethasone. This is again a question that has been asked. Is that clear to everyone? If I talk about investigation of choice, of placenta previa, that is going transvaginal scan, TVS. For screening, we do transabdominal scan, but the investigation of choice is going to be TBS. Is that clear to everyone? Is placenta previa clear to everyone? Okay, and remember that most of the cases we finalize this placenta previa condition in the third trimester, because placental migration occurs up till 3rd trimester. That means most of the cases when the placenta is in the lower segment, but by the end of coming close to the 3rd trimester or in the 3rd trimester, this placenta goes to the upper side. That is called as placental migration. So we finalize it at 32-34 weeks only. So if a patient is coming to you, again a PYQ question in the NEET PG, if a patient is coming to you at 23 weeks, diagnosis of a placenta previa, or patient is having a low-lying placenta, what will be your next steps? I will do USG again in 3rd trimester, because most of the cases placental migration occurs and placenta will be in the upper segment. Is that clear to everyone? Placenta previa clear to everyone? So now tell me the answer of this question. You have a lady coming to you, so she is 32 weeks pregnant. There is a painless vaginal bleeding. There is no abdominal pain, non-tender uterus. There are no uterine contractions. Cervitals are stable. It's a low-lying placenta. What will be your answer? Write down in the comment section. What will be your answer? What will be your answer, guys? What will be your answer? Yes. What will be the answer? The answer is going to be C, sir. I will admit the patient. Answer is going to be C. I will admit the patient for the observation and initiate the corticosteroid therapy. I will admit the patient for the observation and initiate the corticosteroid therapy. Very good. Everyone is right. Very good. Sir, immediate cesarean. At 32 weeks, क्यों ही cesarean करोगे? Any patient coming to you with a vital stable, she has vital stable, 32 weeks, fetal lungs are not even fully matured. Okay? Why you will go for cesarean section? PV तो करोगे नहीं. Pervaginal is not done in the antepartum hemorrhage. Discharge the patient. No, you have to admit the patient, observe the patient and initiate the corticosteroid therapy. But in case, anytime there is a fetal distress, mother is unstable, patient is having distress, bleeding is going on, you have to go for cesarean section. At that time, you will not wait. Is that clear? That's why I have mentioned in expectant management. Patient should be hemodynamically stable. Number first thing, guys, patient should be hemodynamically stable. Second, there should be no active bleeding or there should be no fetal distress. If anything other than that, you will mark a cesarean section. Chalo, next question. Now answer the second question in case of placenta previa. This one should be right from, you should get this one correct. A primary gravida at 37 weeks. The first thing that we'll look in these questions, the first thing that we'll check in this question is going to be, सबसे पहले क्या चेक करोगे? Period of gestation. पहले देखा करो 37 weeks, term pregnancy, labor room with anterior placenta previa, with painless vaginal bleeding. The fetal heart rate was normal at the time of examination. At the time of examination, fetal heart rate was normal. But the best management, 37 weeks, the best management, os is covered by the placenta previa. So there is no mechanism of what? Normal vaginal delivery. We are going with cesarean section. Everyone answer? Everyone? Yes? Is placenta previa clear? Is placenta previa clear to everyone? Somebody is saying A. How can the A be answer? I mentioned that less than that, we'll go with the A, okay? Chalo. Can we move to the next question, guys? So let's have a quick recap of this placenta previa, okay? Few points. First thing, placenta previa. It's a condition when the placenta is in the lower segment, partially or the completely. It's covering the os. Second point, the presentation of the patient is important. That means the patient will complain of a painless vaginal bleeding. There is non-tender uterus, soft uterus. The uterine size will correspond to the period of gestation. Third point, the management. Sir, if a patient is having more than 37 weeks, you're going with cesarean section. If a patient is having less than 37 weeks, I'm going with an expectant management. Sir, what exactly is expectant management? You only go with the expectant management when the patient is hemodynamically stable, when the patient does not have any fetal distress, or the patient does not have any active vaginal bleeding. Then you go with the regime called as McFay-Johnson regime. So the McFay-Johnson regime says that you admit the patient, you arrange the blood. If a patient is Rh negative, you give anti-D and give steroids for the fetal lung maturity. Next, the test to check the fetal lung maturity is going to be your lecithin sphingomyelin ratio. Second is going to be phosphatidylglycerol. Third is going to be phosphatidylcholine. We have also one more test, shake test. Okay, all the tests are done for the fetal lung maturity. If I talk about the investigation of choice of placenta previa, that's going to be transvaginal scan. If I talk about this for screening, transabdominal scan. Is that clear? And most of the times, if a question will ask, our patient is a case of a placenta previa at 25 weeks. What you just next step, do USG again, do the scan again at 32 weeks. Okay, next question. Next topic, next question. Okay, a 32-year-old pregnant woman at 36 weeks, a 32-year-old pregnant woman at 36 weeks gestation, she presents with a sudden onset severe abdominal pain. A patient at 36 weeks with a severe abdominal pain, vaginal bleeding, and a tense and a tender uterus. So exactly opposite of what? Placenta previa. So you have to check severe abdominal pain, patient complains of severe abdominal pain, vaginal bleeding, a tense tender uterus. The fetal heart rate monitor reveals the fetal bradycardia. What is the next best step in the management? So what is your diagnosis first? Write down in the comment section, what is your diagnosis? What exactly is your diagnosis? Surfactant you will check. You will mark surfactant, lecithin sphingomyelin. What is your diagnosis, guys? Yes. A patient coming to you with a 36 weeks gestation presents with a sudden onset severe abdominal pain. There is a vaginal bleeding, painful vaginal bleeding with a tense uterus, a tender uterus, but a fetal heart rate monitors that there is a fetal bradycardia. What is the next best step in the management? Very good. The diagnosis is very good. The diagnosis is abruptio placenta. The diagnosis is abruptio placenta. Okay. Now, what will be your management? What will be your management? What will be the answer? Most of you got it right. The answer is going to be immediate cesarean section. Immediate cesarean section. section. Okay, now again in abruptio placenta we have a different cases. Okay, in which conditions I will mark cesarean section, and in which conditions I will go with the conservative management. Okay, now let's discuss what exactly is abruptio placenta. What is abruptio placenta, guys? The abruptio placenta means there is premature separation of normally implanted placenta. There is premature separation of normally implanted placenta. Okay, now what are the risk factors of this abruptio placenta? First of all, a patient having a hypertension. Okay, then you can write preeclampsia, eclampsia, because both these conditions have a patient increased BP more than 140/90. So any case of hypertension is a risk factor of abruptio placenta. Patient having trauma, premature separation, patient having a trauma, patient having a trauma, patient having trauma. Next, multiparous woman. Next, multiparous woman, or any case of previous abruption. Any case of previous abruption. Is that clear? So what exactly is abruptio placenta? When there is a premature separation of a normally implanted placenta. So you can see in the image, there is a premature separation of a normally implanted placenta. Now this abruptio placenta, what can be the reason? The reason can be PIH, the reason can be hypertension, trauma, multiparous woman, or the previous abruption. We have types of abruptio placenta. What are the types? We have concealed, we have revealed, we have concealed, or we have revealed, or we have mixed. We have concealed, we have revealed, or we have mixed. Okay, so what is concealed type of abruptio placenta? What is concealed type? Can you see? Look at the image, my dear students. In the image, a patient is having an abruptio placenta, patient is having a bleeding, but this bleeding is intact. It does not escape the placenta, it does not escape the membranes. This is intact. Okay, and what is revealed? A bleeding comes out. Here the bleeding is escaping and it comes out. Okay, and that is revealed, and the most common type is revealed abruption. Is that clear? So what is concealed? So concealed is patient is having abruptio placenta, patient is having abdominal pain, patient is having tender uterus, fetal heart sound may be absent. Okay, that is a case of a concealed abruption. But in the same case, if a patient is bleeding, in the same case patient is bleeding, that is going to be revealed abruption. That's going to be revealed abruption, and that's going to be the most common type. That's going to be the most common type. Is that clear? Is that clear? Yes. Now next thing guys, in a case of an abruptio placenta, what will happen if a question will mention that the fetal parts are palpable? Patient coming to you with a vaginal bleeding, tender uterus, fetal parts palpable. Your answer is going to be comment down. What you will answer if a patient is coming to you with a tender uterus, painful vaginal bleeding, fetal parts palpable. If you can palpate the fetal parts, your answer is going to be uterine rupture. That is a case of a uterine rupture, because the parts will be in the abdominal cavity. You can directly palpate them. And if they mention fetal parts are not palpable, your answer is going to be abruptio placenta. Your answer is going to be abruptio placenta. Third scenario, if a question comes, patient is having a tender uterus, pain abdomen, fetal parts cannot be palpable, then it's going to be your concealed abruption, because the bleeding is not escaping out. And if a patient mentions the bleeding, your answer is going to be the revealed abruption. Okay, now sir, how exactly will be the presentation of a patient? So patient will usually come with a painful vaginal bleeding. So patient is coming to you with a painful vaginal bleeding. Next, it's usually in third trimester. It's usually in third trimester, and a bleeding is dark red in color. Bleeding is dark red in color. Even the classical case, the clinical case that the examiner can ask, he will mention that a blood stained liquor is seen. What is liquor? Amniotic fluid. And if the color of an amniotic fluid is red color, that indicates an antepartum hemorrhage. Usually which one? Dark red color liquor, dark red color amniotic fluid is a case of an abruption, is a case of an abruptio placenta. That means placenta is separated abruptly, all of a sudden, premature. Is that clear? Okay, now per abdominal examination. What is per abdominal examination? The uterus is tender. The uterus is tender and rigid. Okay, the fetal heart sound not heard. Fetal heart sound not heard. Okay, fetal parts not palpable. Fetal parts not palpable. My dear students, I've already mentioned, if palpable, if a case comes with a painful vaginal bleeding with a tender uterus, and if it is palpable, rupture. If it is not palpable, abruptio placenta. If bleeding is there, reveal abruptio. If bleeding is not there, concealed abruption. Remember the things. Next, the height of uterus. The height of uterus is more than period of gestation. The height of uterus is more than the period of gestation. The height of the uterus is more than a period of gestation. Is that clear? And this picture, what exactly is this picture? Anyone? What exactly is this picture? They can ask the image based question. Okay, then they can give you this picture. What exactly is this picture? What is this called as? This is called as, yes, write down in the comment section. This is a uterus and abruptio placenta called as covalier uterus. Sir, it's called as covalier uterus. Sir, what exactly is covalier uterus? It's a bruised uterus. It's a bruised uterus. How exactly we get this bruised uterus? Due to the extravasation of the blood into the uterine musculature. Okay, due to the extravasation of blood into uterine musculature. Okay, and this type of bruised uterus is seen in a abruptio placenta, covalier uterus. Image based question they can ask. Now we have a classification, guys. We have a classification called as Page's classification. What exactly is Page's classification? Grade 0 says asymptomatic. Grade 0 says asymptomatic. Okay, grade 1 mild, grade 2 moderate, and grade 3 is severe. Grade 1, grade 2 and grade 3, that's mild, moderate and severe. Okay, what exactly is grade 1? There is pain plus bleeding. Patient is having pain plus bleeding, but the fetal heart sound is going to be normal. The fetal heart sound is going to be normal. What exactly is grade 2 moderate? Fetal distress is seen. Fetal distress is seen. Okay, and what exactly is grade 3 severe? Patient is going to have a fetal death plus there can be maternal shock. There will be fetal death plus maternal shock, or plus minus DIC, or plus minus DIC. Is that clear? So we have a grade of a abruptio placenta, grade 1, grade 2 and grade 3. We have grade 1, grade 2 and grade 3, mild, moderate and severe. Mild, moderate and severe. Okay, now the most important part. Okay, the most important part is going to be your management. The most important part is going to be your management. Now if a patient is coming to you in a term pregnancy, the patient is coming to you in a term pregnancy, okay, what will be your management? Write down in the comment section. Now if a patient is coming to you in the term pregnancy, first of all, write down, guys, if fetal distress is there, or if fetal scalp pH is less than 7.2, that will indicate a fetal hypoxia. Okay, what you will mark, bacho? Sir, anytime question mentions that patient is having a fetal distress, a patient is having a fetal scalp pH less than 7.2, fetal heart rate less than 100, any condition you mark, or any unstable condition you mark what? Cesarean section. Okay, and if patient is not having any distress, patient is stable, mother and baby both are stable, we are going with a normal vaginal delivery. We are going with a normal vaginal delivery. But sir, how come we will go with the normal vaginal delivery? Because there are no contractions. So when we are inducing the contractions before the onset of the time, when we are inducing the contractions, that's called as induction of labor. So we'll go with the induction of labor. So how we will do this induction of labor? We are going to we are going for artificial rupture of membranes. What will these artificial rupture of membranes do? So they will release the prostaglandins. What will these prostaglandins do? These prostaglandins will induce the labor. So what will be your answer for the question if it mentions that patient is stable, baby is stable, case of abruption? Your answer is going to be normal vaginal delivery with artificial rupture of membranes, because artificial rupture of membranes will release the prostaglandins, endogenous prostaglandins are released, and these prostaglandins are going to induce the labor. Is that clear? Okay, so patient in the term fetal distress, scalp pH 7.2, less than that, cesarean section. If 32 to 34 weeks, if less than that, first of all, first management in all these conditions, so I am going with resuscitation. Okay, and then you are giving steroids to mother. And remember guys, no cesarean section. Okay, you will go with artificial rupture of membranes. What is ARM? Artificial rupture of membranes. What will happen, sir? Prostaglandins are released. And what will this do? They will induce labor. These prostaglandins will induce the labor. Is that clear to everyone? So patient coming to you with a pain abdominal and vaginal bleeding. There is a tender uterus, period of uterine size is more than the period of gestation. This is a classical case of abruptio placenta. And now if I ask the management at 37 weeks, now come back to the question. So the keyword you have to remember, normal vaginal delivery with artificial rupture of membranes. Okay, why to go with cesarean section if everything is normal? Because abruptio placenta means that there is a premature separation. It does not mean that the placenta is in the lower segment. Cesarean section tab karte jab os should be covered with the placenta, but that is the case of placenta previa. So here what you do is, there are no contractions, so we'll induce this contraction with the help of artificial rupture of membranes, which will release the prostaglandins and then give oxytocin to the patient and deliver the baby. Is that clear? Now if a patient, now the question, 36 weeks, severe abdominal pain, vaginal bleeding, tense and tender uterus, fetal heart rate reveals the fetal bradycardia. That means baby is in the distress. And when a baby is in the distress, what is your answer for that? Baby in the distress, what is your answer for that? What will be your answer for that? Baby in the distress. Write down the answer. Baby in the distress. Write down the answer. Cesarean section. Write down the answer. The answer is going to be cesarean section. The answer is going to be cesarean section. Is that clear to everyone? Is that clear to everyone? Good. Try to be interactive. Write down your answers. Revise. Okay. Because till now I think you all have studied or revised your OB-GYN once. So right now just revise. Okay. Just type the answers. Recall all the stuff that you have studied. Okay, all the faculties teach the same thing. There is nothing different. Okay, So keep revising. Whatever your source is, keep revising. Next. Chalo. A 35-year-old, look at the question. Now I want answers from all of you. The one question I show prior to the topic. You are allowed to make a little mistakes. But once I go through all the topic, once I deliver all the topic in the depth, in a detail, the next question after the topic that I'm showing you, there is no chance of making any mistake. Okay. A 35-year-old Gravida 3 Para 2 Live 2 with 36 weeks of pregnancy was admitted in the labor. The blood pressure is 150 by 100. After 4 hours, she complained of a severe abdominal pain. She complains of a severe pain abdomen in between the uterine contractions. The uterus is 36 weeks. Fetal heart rate is 100 per minute. Per vaginal examination, cervix was 4 centimeter dilated. Membranes ruptured, showed blood stained liquor. She was prepared for the LSCS. On doing laparotomy, this was the uterus. All steps are to be done except. What was the uterus image? The image is this one. So what is your diagnosis first? So many hints. Patient is hypertensive. Okay, severe abdominal pain. Okay, severe abdominal pain. The membrane ruptured, showed blood stain liquor. That means a red color amniotic fluid. Okay, and this red color amniotic fluid, it is a classical case of what? All these things. Image as well. Cochlear uterus. Sir, it is a diagnosis of abruptio placenta. All are to be done except. All of the following are to be done except. क्या नहीं करोगे? Write down your answers. All are to be done except. All are to be done except. No need of hysterectomy, sir. Uterus क्यों निकालना है? Why? We'll go with the yes, this is a cochlear uterus. Answer is going to be D. Do hysterectomy. We don't do hysterectomy in abruptio placenta. मैंने कहीं बोला क्या? I did not, from the last 45 minutes जब से सेशन स्टार्ट हुआ है मैंने hysterectomy की बात ही नहीं की. So what is your answer? No hysterectomy. Is that clear to everyone? Is that clear to everyone? Yes. A quick recap of abruptio placenta. First of all, sir, it's a antepartum hemorrhage. Second, it's a premature separation of a normally implanted placenta. The risk factor can be a hypertension or the trauma, or a previous abruption as well, or a multi-gravida or the multi-paras woman. The presentation of the patient is painful vaginal bleeding. There is a tender uterus. The fetal heart sounds are not heard, but the fetal parts cannot be palpable. If we palpate these fetal parts, it's going to be a case of a rupture, uterine rupture. Is that clear? Next part, there are 3 types: concealed, revealed and mixed. In revealed, the blood escapes the membranes and coming out. In concealed, there is no bleeding. In concealed, there is no bleeding. Is that clear? Is that clear? Management: if a patient is in the distress, mother is unstable, term cesarean section. If not, go with a normal vaginal delivery with the artificial rupture of membranes. Okay, what will this artificial rupture of membranes do? So they will release the prostaglandins, contractions, and patient will have induction of labor. We induce the labor. What is augmentation of labor? When the labor needs enhancement, when the contractions are not enough. Okay, there are contractions but they are not adequate, so those contraction needs enhancement, and that is called as augmentation of the labor. Okay, is abruptio placenta, in case of abruptio placenta we are doing ARM, is this an induction of labor or augmentation of labor? Is that an induction of labor or augmentation of labor? That is an induction of labor. Okay, if the labor needs enhancement, if the patient is already having contractions, a little dilatation, उसके बाद अगर करोगे, that is an augmentation. चलो, the extravasation of blood into the uterine musculature, that's going to be your cochlear uterus. That is going to be your cochlear uterus. Next, can we move to the next topic? Placenta previa and abruptio placenta is clear. Placenta previa and abruptio placenta is clear to everyone. Yes. Chalo. Next question. A 28-year-old woman at 34 weeks of gestation. A 28-year-old woman at 34 weeks of gestation presents with a painless vaginal bleeding. Again, a bleeding is painless. A baby is having a fetal bradycardia. There is a fetal bradycardia. On ultrasound, there is a filamentous cord insertion with fetal vessels. There is a filamentous cord insertion with fetal vessels crossing the internal cervical os. Crossing the cervical os. What is your most likely diagnosis? 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 Write down in the comment section. What is your most likely diagnosis? Yes. Mixed answers. Some are saying placenta previa, some are saying vasa previa. Okay, let's discuss and then get back to this question. Okay, the condition is a vasa previa. What is the condition, guys? Vasa previa. So what is a vasa previa? Again, a antepartum hemorrhage condition. Sometimes it mimics with a placenta previa. Why? Because both placenta previa and vasa previa, are a painless conditions, okay. But when a question mentions V for vasa previa, V for filamentous cord, okay, if there is a filamentous cord present at os, that is vasa previa, or the splitting of the cord, at os, that is your vasa previa. So filamentous cord present at the os or a splitting of a cord at os, that is a diagnosis of vasa previa. Now we have type 1 vasa previa and type 2 vasa previa. We have a type 1 vasa previa and type 2 vasa previa. You can see type 1 vasa previa, the vasa previa with cord insertion. These are the filamentous cord at os. This filamentous cord insertion at os is going to be vasa previa. So what is difference between type 1 and type 2? In type 2 vasa previa, we have a bilobed placenta. Can you see placenta with the two lobes, one lobe, second lobe? That is called as bilobed placenta. Okay, you might have studied from your primary notes different types of placenta: battledore placenta, filamentous type of placenta. Okay, and we have one more type that is called as bilobe placenta. Which type of placenta we have a bilobe? Succinureate placenta. Okay, succinureate placenta. Okay, that is a bilobe placenta, that is contributing to the type 2 placenta previa. What is the presentation of a patient, sir? Patient will complain of painless bleeding. Okay, next, patient will have a fetal distress. Okay, with no tenderness. And most in case of a vasa previa, remember, in case of a vasa previa, the origin of bleeding is maternal or fetal? Yes, medicine jobs, fetal distress because of the fetal blood loss. So what is the origin of bleeding? In case of a vasa previa? What is the origin of bleeding in case of a vasa previa? So that is going to be fetal. Okay, the origin of bleeding is usually what? Fetal. The origin of bleeding is going to be fetal side. Okay, now how exactly we are going to diagnose this? First of all, we are going with transvaginal scan with the Doppler, with color Doppler, to examine the fetal vessels. Okay, बोना maternal में कहाँ होगा? That is the fetal side. Origin of the bleeding is the fetal side. Then we do a test called as AP test or alkaline denaturation test or alkaline denaturation test. We also call it as Singer's alkali test. क्या बोलते हैं? Remember all the names because they can ask anything. Singer's alkali test. Okay, this test is done to differentiate between the maternal and the fetal blood. This test is done. This test helps us. This test helps us to distinguish between maternal and fetal blood. It helps us to distinguish between a maternal and a fetal blood. The fetal RBCs, they are resistant to the alkaline denaturation test. Fetal RBCs are resistant to the alkaline denaturation test, and if it is colorless, the blood is maternal. If it is colorless, it is maternal blood. And as I've already mentioned that the fetal RBCs are resistant to this alkaline denaturation test, and if it stays red only, the is fetal blood. That's going to be your fetal blood. Is that clear? That's going to be your fetal blood. That's going to be your fetal blood. Okay, the management is going to be cesarean section. The management is going to be cesarean section. अगर normal vaginal delivery करेंगे, there are the fetal filamentous cord insertion at the os. If you do the normal vaginal delivery, there is a rupture of this. It will cause more blood loss. It will cause more blood loss. So what is the management? What is the management? यहाँ पे भी rupture होगा, bilobed है. What is the management? Cesarean section. What is your management, guys? Cesarean section. Is that clear? Is that clear to everyone? Yes? Chalo. Next question. A 25-year-old woman at 32 weeks of gestation is diagnosed with the placenta previa. Sorry, is diagnosed with a vasa previa. What is the preferred method of delivery in this situation? She has been diagnosed with a placenta previa. What is the preferred method of delivery? What is a preferred method of delivery? A case of a vasa previa. A case of vasa previa. What is the method of delivery? Write down your answers. Write down your answers. Yes, everyone. What will be the answer? Good. The answer is going to be elective cesarean delivery at 34 to 36 weeks. Sir, why not that time only? Because I'm just mentioned, I have the question that the patient is diagnosed with vasa previa. There is no current bleeding, okay? So you will plan the elective cesarean. You will plan the cesarean section by 34 to 37 weeks. And I've already mentioned, if you'll go for the normal vaginal delivery, there is a filamentous cord present at os. once you try to deliver the patient normally, there will be a rupture of the vessels that will cause more fetal loss, more bleeding. So your answer is going to be cesarean section. So V for vasa previa, V for filamentous cord insertion. So that completes your 3 topics, your placenta previa, your abruptio placenta, and the next one, vasa previa. All clear to everyone? All clear to everyone? And that completes your full big chapter, antepartum hemorrhage. Okay, just 1, 2, 3, 4, 5 and 6 slides. That completes your antepartum hemorrhage. Is that clear to everyone? Is that clear to everyone? Yes. Chalo. Antepartum. Now next question. So the answer here is going to be, sir, elective cesarean delivery at 34-36 weeks. Clearly clear. Yes. Yes, you guys will get the PDF. Yes, Amir bro. Thanks. Okay. Chalo. Next. Let's begin with a quick recap of a chapter. So I mentioned first thing, antepartum hemorrhage. Antepartum hemorrhage is a hemorrhage that occurs after 28 weeks till the time of delivery. We have 3 things: placenta previa, vasa previa, abruptio placenta. Among these 3 conditions, the only one condition, the patient will have a painful vaginal bleeding with a tender uterus. Your answer is going to be abruptio placenta. Rest other 2 conditions, you have a painless vaginal bleeding with a soft and non-tender uterus. Either it can be a vasa previa or placenta previa. If there is a filamentous cord insertion, or if splitting of the cord occurs at the os, or if there is a bilobed placenta, your answer is going to be vasa previa. Other than that, that's going to be placenta previa. Clear to everyone? In case of a placenta previa, if at term you mark the cesarean section, if less than 37 weeks, you go with an expectant management. What is an expectant management, sir? So that's a management, McFay-Johnson regime. I admit the patient, I arrange the blood and give steroids to the mother, beta-methasone, dexamethasone, and if Rh negative, give anti-D. Is that clear? Give anti-D. Clear to everyone? If I talk about abruptio placenta, we have 2 types, concealed and revealed. If the bleeding is escaping, that the answer is going to be revealed. If not, that's going to be concealed. We have an extravasation of a blood into the uterine musculature, giving a picture of a covulate uterus or a bruised uterus. If a patient is having a fetal distress or unstable, you mark cesarean section. If not, you go with a normal vaginal delivery with artificial rupture of membranes. Is that clear? This artificial rupture of membrane will release the prostaglandin that will induce the labor. Management of a vasa previa, cesarean section. That's all. Is that clear? Is that clear? That's all about APH. No need to remember the causes. Focus on the management. OB-GYN is a clinical subject. Focus on the management. Okay. Chalo. Which of the following is the most probable cause of bleeding per vaginum occurring 24 hours after the delivery? Now, next chapter, postpartum hemorrhage. Now tell me the answer. Now tell me the answer. Next chapter, postpartum hemorrhage. Dr. Puneet. What will be the answer? Mixed answers, uterine atony, uterine atony, uterine atony. Okay. Whenever you see postpartum hemorrhage, you mark atonic uterus. No. Sir, most common cause of postpartum hemorrhage is uterine atony. Okay, yes, that is a postpartum hemorrhage, but I am mentioning it is after 24 hours. Chalo, let me correct you guys. Some are with the right answers. Now let's discuss full chapter. Okay. Let's discuss this chapter. Now, first thing, definitions of the postpartum hemorrhage. So, bleeding after the delivery. What exactly is the diagnosis? That's going to be your postpartum postpartum hemorrhage. Now what exactly is postpartum hemorrhage? Any bleeding from the genital tract, after the delivery till 12 weeks. The answer is going to be PPH, postpartum hemorrhage. Now this postpartum hemorrhage, it can be of two types, primary and secondary. This postpartum hemorrhage can be either primary and secondary. What is primary? Within 24 hours. Within 24 hours. What is secondary? After 24 hours. After 24 hours. But till how long? Anyone in the comment section? After 24 hours till? After 24 hours till 12 weeks. Not 6 or 12, till 12 weeks. Till 12 weeks. Okay? Till 12 weeks. Chalo. Now let's discuss about definitions of the postpartum hemorrhage. What exactly is postpartum hemorrhage? It's a blood loss. It's a blood loss in case of a normal vaginal delivery when it exceeds more than 500 ml. And it's more than 500 ml. Okay? Or blood loss in case of cesarean section. Blood loss in case of cesarean section more than 1000 ml. Blood loss more than 1000 ml. Okay? Or either the bleeding which can reduce hemoglobin, which can reduce the hemoglobin by 1 gram %. Bleeding which can reduce the hemoglobin by 1 gram %. Okay, that is different. Maternal mortality, that is different. You take that into the consideration from the day of pregnancy till the 42 days or the 6 weeks. Okay? Bleeding which can reduce the hemoglobin by 1 gram %. Okay? Or bleeding which can reduce the hematocrit value, by 10%. Or any bleeding exceeds more than 1000 ml. Lot of definitions. Okay? Blood loss in NVD more than 500, in cesarean more than 1000. Bleeding which can reduce HB by 1 gram %, which can reduce the hematocrit by 10%. Bleeding exceeds more than that. That is going to be all what? Postpartum hemorrhage. Postpartum hemorrhage. Is that clear? Is that clear? Now sir, we have types: mild PPH, moderate PPH and severe PPH. What is mild? When it's more than 500 to 1000. What is moderate? 1000 to 2000. What is severe PPH? More than 2000 ml. More than 2000 ml. Is that clear? Okay. Now blood loss exceeds more than 1500. Any blood loss which exceeds more than 1500 is going to be a massive obstetric hemorrhage. That is going to be massive obstetric hemorrhage. That's going to be massive obstetric hemorrhage. Is that clear? Now what exactly is obstetric hemorrhage? Sir, obstetric hemorrhage means two. One is antepartum, another is postpartum. So even if a patient in antepartum hemorrhage, either the case of placenta previa, vasa previa and abruptio placenta, if it exceeds more than 1500 ml of blood, that is a massive obstetric hemorrhage. If it occurs before the delivery, it's going to be APH. If it occurs after the delivery, it's going to be PPH. Okay? Now what exactly are the causes? What exactly are the causes of a postpartum hemorrhage? What are the causes of postpartum hemorrhage? Okay, number first one is tone, decreased tone. Okay, number second one is going to be trauma, tone, trauma. Then thrombin deficiency, and then tissues. Thrombin deficiency and tissues. Okay, so we have tone, we have trauma, we have thrombin deficiencies, and we have tissues. Is that clear? Sir, the most common cause of a primary PPH, that is an atonic uterus. What is atonic uterus? When the tone is decreased, when the tone of a uterus is decreased. So what is the risk factor of this decreased tone? Due to the over distension of the uterus. Okay, कैसे होगा? Due to the over distension of the uterus. Due to the over distension of the uterus. When there is an over distension of the uterus, there is decreased tone. So what is over distension of the uterus? Simple language, when there is a large uterus. When there is a large uterus. Okay, now large uterus, what are the conditions a mother can have a large uterus? First of all, if there is polyhydramnios, case of a polyhydramnios, when the amniotic fluid index is more than 25, that is a polyhydramnios. Okay, then if it is a case of a twin pregnancy, if it is a case of a twin pregnancy, if it is a case of a twin pregnancy, again a patient will have what? Large uterus. Next, if there is a macrosomic baby. What is macrosomic baby? Large baby. How large? More than 4 kg. What is the ideal weight of a baby? 2.93 kg. Okay, but if it exceeds more than 4 kg, that is called as macrosomic baby. And macrosomic baby is seen in which condition? Gestational diabetes mellitus. That is seen in the gestational diabetes mellitus. And when the baby is more than 4.5, that is a classical indication of a what? Cesarean section. Why? Because if we go with the normal vaginal delivery, there are possibilities that the patient will have a brachial plexus injury due to the shoulder dystocia, and also patient can have a rupture. Okay, is that clear? Next, there can be an infection of the chorion uterus, chorioamnionitis. Chorioamnionitis. They are all the causes of what? These are all the causes of a PPH, atonic uterus, when the tone is decreased. When the tone is decreased. Is that clear to everyone? Yes, clear to everyone. Now next, trauma. Trauma में क्या क्या आएगा? If the patient is having lacerations, if the patient is having lacerations, if the patient is having perineal tear, rupture होगा, tear होगा, okay, or if there are hematomas, that goes with the trauma. That goes with the trauma. Is that clear? Is that clear? Then next, thrombin deficiency. Next is going to be the thrombin deficiency. In thrombin deficiency, what are the disorders? You have idiopathic thrombocytic purpura, ITP. Idiopathic thrombocytic purpura, number 1. Number 2 is going to be von Willebrand's disease, VWD, factor A deficiency, and also rarely hemophilias. Blood related disorders, we have ITP, VWD, and hemophilias. Hemophilia A, B, C. In our main classes, we have discussed hemophilia A, factor 8, B, factor 9, C, factor 11, parahemophilia, factor 5, von Willebrand's, factor 8. Which of the following is called as Christmas disease? Factor 9, hemophilia B. Is that clear? A, B, C, 8, 9, 11. Para with 5, VWD 8. Factor 8, VWD is again a question with a knee image, a PYQ from the pathology. Okay, is that clear? So that goes with the thrombin deficiency. And tissues, from tissues, what can cause the bleeding? Retained placental beds. Retained placental beds. Retained placental bed, and that causes usually secondary postpartum hemorrhage. That usually causes secondary postpartum hemorrhage. Is that clear? So what exactly are the 4 T's? So first of all, it's a decreased tone. Second is going to be trauma, lacerations. Third is going to be thrombin deficiency, ITP. So what about antiphospholipid syndrome? No, that will more predispose to the abortions when the patient is having recurrent abortions in case of an antiphospholipid syndrome. Okay, then we have inherited and acquired. I will discuss that in an abortion chapter. What are the all antibodies you will be checking in an APLA? Okay, so APLA is usually causes abortions. There is a factor 5 laden mutation or the prothrombin gene mutation in antiphospholipid antibody syndrome. And in next one, the antibodies that you are going to check in APLA are going to be glycoprotein, beta 2 glycoprotein, are going to be, second one is going to be lupus anticoagulant, and third one is going to be anti-cardiolipin antibody. Remember these three antibodies from the antiphospholipid syndrome. And what is the management? The drug, you will give low molecular weight heparin plus aspirin, APLA. Is that clear? APLA. Anyone else? Hindi. Some students over there from South India, they cannot understand Hindi. Okay? Is that clear to everyone? Tone, nasalations, trauma and tissues. Next. Chalo. APLA. Yes, low molecular weight plus heparin plus aspirin. Now sir, the primary PPH. What exactly is the primary PPH? If it occurs, we have already discussed, if it occurs within first 24 hours, if it occurs between first 24 hours, that is going to be your primary PPH. And the most common cause of the primary PPH is going to be atonic uterus. So what is secondary PPH? The secondary PPH is going to be after 24 hours. And the most common cause is going to be retained placenta beds. Is that clear? Yes. Now what will be the answer of the question? Come back to the question, bacho. Which of the following is the most probable cause of the bleeding per vaginum occurring after 24 hours? Your answer is going to be yes, your answer is going to be retain of placental beds, tissues. Is that clear? So all four options: trauma, tissues, thrombin deficiency and tone, A, B, C, D. Your answer is going to be retained of placental beds. That's going to be a case of secondary postpartum hemorrhage. Is that clear to everyone? Yes. Yes. Next. Chalo. How to differentiate between now atonic PPH and traumatic PPH? Now you have a case of a postpartum hemorrhage, bleeding is there. So how exactly you will check whether the bleeding is due to the decreased tone or whether the bleeding is due to any trauma? So first of all, what you are going to go? You are going for the per abdominal examination. You will examine the abdomen. Okay. After you go for the examination, there can be two scenarios. If uterus is palpable, you are able to palpate the uterus, this is going to be a case of traumatic PPH. This is going to be the case of traumatic PPH. Okay. And if uterus is not palpable, that's going to be, if a uterus is not palpable, that's going to be atonic PPH. That's going to be atonic postpartum hemorrhage. That's going to be atonic postpartum hemorrhage. That's going to be your atonic postpartum hemorrhage. Is that clear to everyone? Next, the important part, that is going to be your management. Okay. So for the prevention of postpartum hemorrhage, we are giving a prophylactic drug. I hope you have studied about AMTSL. What is AMTSL? It's an active management of a third stage of labor. What is active management of third stage of a labor? In order to prevent the complications, in the third stage of labor. So what exactly is third stage of labor? We have four stages, from contractions to dilatation. Okay, from dilatation to the delivery of the baby, from delivery of the baby to the delivery of the placenta, third, then the observation is the fourth. Now what exactly is the third stage of labor? Listen to carefully. Third stage of labor is from the delivery of baby to the delivery of placenta. And most of the complications, okay, when the third stage of labor is not handled properly, most of the complications occur where? Mishandling of the third stage of labor, okay, occur in the Complications occur in the third stage of labor. So what are the complications? Number first thing, we have to PPH, postpartum hemorrhage. Second thing, patient can have a uterine inversion. Okay, patient can have a uterine inversion, or patient can have what? Shock. These all complications occur in which stage of labor? Third stage of labor. And this third stage of labor, in order to prevent these complications like postpartum hemorrhage and uterine inversion, we have a management called as active management of a third stage of labor. So what exactly is this active management of a third stage of a labor? First of all, you administer the uterotonic agent. Okay, you administer the uterotonic agent. Second one, delayed cord clamping. Third one, you deliver the placenta by the control cord traction. Okay, slowly control cord traction. If you do a sudden cord traction, तो क्या होगा? Uterus will turn upside down, cavity में आएगा. That is a uterine inversion. So you go the control cord traction or the Brand and Andrews method. And fourth one is an observation, assessment of the uterine tone. That is going to be what? Active management of third stage of labor. And the active management of third stage of labor, the step 1 of this AMTCL, that says give a prophylactic what? Uterotonic agent which will maintain the tone of the uterus. What is the drug? Yeah, you are giving oxytocin. Is that clear to everyone? Why we are giving oxytocin? In order to prevent the complications. So what are the complications of third stage of labor? So patient can have a postpartum hemorrhage. So patient can have a shock. Patient can have a uterine inversion. So in order to prevent these things, we are going with the prophylactic drug of choice, oxytocin. Again, one question in the recent exams, state exams were asked. Okay, how much prophylactic dose? What should be the prophylactic dose of oxytocin in AMTSAL? What is your answer? 5 to 10 international units. What is your answer? 5 to 10 international units. What is your drug of choice? If they ask what exactly is the drug of choice, your answer is going to be oxytocin. Your answer is going to be oxytocin. So how much of oxytocin you need to give? Now the patient is a diagnosis of PPH. You need to give 20 international units in 500 ml of NS. In 500 ml of NS. Okay, give in the normal saline how much? 20 international units. Sir, why cannot stat, why cannot bolus एक साथ क्यों नहीं देंगे? Again a need PGPY. क्यों? It will cause sudden hypotension. So always remember, when you give oxytocin, you have to give in the drip form. You have to give in a drip form. If you give bolus, it will cause sudden hypotension. Okay, the second drug of choice is going to be your methyl ergometrin. The second drug of choice is going to be your methyl ergometrin. It's going to be your methyl ergometrin or methergin. How much to give? 0.2 mg intramuscular. 0.2 mg intramuscular route. Okay, and it has a peak action in 90 seconds. Okay, after that the contraindications. Again a very important question, my dear students. What are the contraindications of a drug? Which drug? Methergin or methyl ergometrin. What are the contraindication? Number 1, remember, if a patient is a case of pregnancy induced hypertension. If a patient is a case of pregnancy induced hypertension, that includes your both preeclampsia, eclampsia, don't give methyl ergometrin. Second, if a patient is having any heart disease, again that is a contraindication for a drug, methergin. That's a contraindication for a drug, methergin. What is the most common heart disease in pregnancy? Usually we have rheumatic heart disease. What is the most common lesion in RHD? You have mitral stenosis. Okay, next, if a patient is having RH isoimmunization, RH incompatibility, okay, or before the delivery of the second timing, they are all the contraindications. Of a drug. Methergin. Followed by that you give misoprostol. Prostaglandin E1 can also be used. Okay, but if a patient is not having any relief after the oxytocin and methergin, directly go with the carboprost. Okay, the question was asked that a patient is resistant to all routine drugs of PPH. That means oxytocin and methogen. Patient is resistant to all routine drugs of PPH. What is the next drug you will use? You will use the injectable drug, that is carboprost. Carboprost belongs to which class of prostaglandins? PGF2 alpha. It belongs to PGF2 alpha. Is that clear? And how much to give? How much carboprost you will give? Sir, the dose of carboprost 0.25 mg. Okay, one dose is 0.25 mg. And how many doses you can give? You can give maximum of 8 doses. Need PGPYQ. PGF2 alpha used in PPH. The maximum dose of a drug that can be given is, your answer is going to be 0.25 into 8. That answer is 2 mg. Again a question. Is that clear? Most potent drug, carboprost. Resistant to all routine drugs, the next drug you will give, carboprost. Injectable drug, carboprost. Is that clear? Is that clear? After carboprost, to stop the bleeding also, we also use tranexamic as a transostat. We give tranexamic. We can use tranexamic acid as well. How much to use? 1 gram. 1 gram in 100 ml of NS. 1 gram in 100 ml of NS. Yes, the most potent drug, PGF2 alpha, that is going to be your carboprost. Why I have mentioned the class as well? Because now they don't ask the drug, they ask the class of the drug. They ask the class of the drug. Is that clear? So followed by injection carboprost, we can use a drug tranexamic acid. Is that clear to everyone? Followed by that, if a patient is having any thrombin deficiency disorders due to which the patient is having postpartum hemorrhage, we can use fresh frozen plasma. We can use fresh frozen plasma, or followed by that we can use balloon tamponade. Followed by that we can use balloon tamponade. Medical management of a PPH is clear. Now postpartum hemorrhage occurred. First of all, I am giving a prophylactic drug of choice, that is going to be your oxytocin. How much oxytocin I'm using? I'm using 5 to 10 international units. Followed by that, if a patient is a diagnosis of a PPH, I'm using 20 international units in 500 ml of NS. If I'm using all of sudden, it will cause a sudden hypotension. So remember, no bolus. This is again a question. No bolus, it will cause a sudden hypotension. Second drug of choice is methylergometrin, 0.2 mg, the peak action in the 90 seconds. But again, we have a contraindication of this drug. Most important question, what are the contraindications? The pregnancy induced hypertension, heart disease, RH isoimmunization, or before the delivery of the second twin. Is that clear? Followed by that, we give prostaglandin E1, misoprostol. We give carboprost, okay, dose 0.25 mg, maximum 8 doses and 2 mg. Is that clear? Then we can give tranexamic acid, fresh frozen plasma, and balloon tamponade. We also give a combination of the drugs like symptometrin. What is symptometrin? Oxytocin plus methylergometrin, है ना? 0.2 mg of methylergometrin and 5 international units of oxytocin. We give symptometrin as well. Okay, then carbetocin as well. These are the mixed drugs, mixed preparation of the drugs. But you just remember this much for now. Just remember this much. Is the management clear so far? Medical management of postpartum hemorrhage is clear so far, everyone? Medical management is clear so far? Yes, chalo, next. Now the balloon tamponades. Now sir, these balloon tamponades will cause a mechanical compression. क्या होगा इनकी वजह से? They will cause mechanical compression of the, which will help in preventing or decreasing the blood loss. The balloon tamponades that we use is going to be Bakri's balloon. The balloon tamponade that we use is a Bakri balloon. And what is the capacity of the Bakri balloon? 500 ml. What is the capacity? 500 ml. Okay, this is going to be your Foley's catheter. और क्या यूज करते हैं? Foley's catheter. What is the capacity? 150 ml. What is the capacity? 150 ml. What is the capacity? 150 ml. Then we use other tamponades as well. We use a sanguine tube. Okay, we also use a very cheap in India, condom catheters. Okay, condom catheters. So once the bleeding is stopped, one MCQ you will see, once the bleeding is stopped, after how long you will take this Bakri balloon? Remove after 12 hours. Remove after 12 hours. Once the bleeding is stopped, then remove after 12 hours. Is that clear? Is that clear? And now medical management, mechanical compression, tamponades, bleed is not stopping. We are going with the surgical methods. Now the next part is going to be your surgical methods. Now, so what exactly are the surgical methods that we do? Now the first thing is going to be the compression sutures. First thing is going to be your compression sutures. Now what exactly are the compression sutures? The most common compression suture that we use, the most common compression suture that we use is going to be your B-link suture. The most common that we use is going to be your B-link suture. Is that clear? Okay. The second other sutures we use like Heyman suture. Just remember the names. We use square suture, square shaped sutures we do on the uterus, or gun shell sutures, or gun shell sutures. So what are the sutures? Or B-link sutures, we have square sutures, or gun shell sutures. These are the B-link sutures. These are the B-link sutures. You can see the suture is passing from the anterior side, and this one suture is passing from the posterior side. So when you suture the uterus from anterior side and the posterior side, they should meet at one point. They should compress the uterus at one point. That is called as B-link suture or the compression suture. What is that called as? B-link suture or compression suture. Okay. Now followed by that, we are going for the artery ligation. We are going for the artery ligation. So what are the arteries that we are going to ligate? Remember the order of the artery ligation. First of all, we are going to ligate uterine artery. First of all, we are going to ligate the uterine artery. Second one, we are going to ligate the ovarian artery. We are going to ligate the ovarian artery. The third one, we are going to ligate the internal iliac artery. Which branch? Anterior or posterior? We are going to ligate anterior branch of internal iliac artery. Internal iliac artery. Is that clear? Is that clear? Again, a question asks that what is an order of the artery ligation. So what exactly is the order of the artery ligation? We are going with a uterine artery, we are going with the ovarian artery, and then our anterior internal iliac artery. Is that clear to everyone? Anterior internal iliac artery. Sir, why not posterior? Because posterior is going to your lower limbs, and if you ligate blood supply को बंद करोगे तो क्या होगा? Patient will complain of what? Patient will complain of numbness, paralysis, numbness in the lower limbs. Is that clear? Now remember, if a classical anatomy question will come, if a clinical anatomy question will come, that a female is coming to you with the complaints of what? Female is complaining with the complaints of numbness. Patient gave a history of a devascularization because patient had a history of postpartum hemorrhage, or patient had a bleeding. Patient had a bleeding after the delivery, followed by which devascularization was done. Which of the following artery has been ligated accidentally by the doctor? Which of the following artery? You will remember the branch of what? Posterior iliac artery. Posterior branch. So remember these three branches, and in case if a question mentions that a patient is having numbness, so that means doctor has ligated these three branches. What are these three? Superior gluteal. So remember the posterior branch, superior gluteal, SG, iliolumbar, 1, 2, 3, and lateral sacral. So you remember with the super gills, okay, SGILLS. Okay, so remember that if a superior gluteal, iliolumbar, or the lateral sacral is ligated or devascularized in case of a PPH, what will happen? Patient will complain of a numbness. Patient will complain of a numbness in the lower limb. So always remember that you have to ligate the internal, you have to ligate internal iliac artery anterior branch. Is that clear? And if the bleeding is not stopped, you go with the hysterectomy. First you go with the subtotal hysterectomy, and then if not, total hysterectomy. Subtotal mein uterus out, total mein cervix plus uterus both you take out. Is that clear? Is that clear? So that was all about what? That was all about your postpartum hemorrhage. That was all about your postpartum hemorrhage. All clear? All clear? Postpartum hemorrhage. Cause is clear. Now exactly, what exactly is the cause of PPH? Yes, you know 4 T's: tissue, tone, thrombin, trauma. But what exactly is coming from? Mismanaged. It's a complication of third stage of labor. It's a complication of which stage of labor? Third stage of labor. That's why for the third stage of labor, we have an active management of third stage of labor. Is that clear to everyone? Is that clear to everyone? Is that clear to everyone? Yes, sir. Clear. Then answer me this question. Write down in comments. Mention your answers in comment section. चलो बता दो आंसर. Tell me the answer. A. Uterine artery ligation. What is the answer? Somebody is A, somebody is C, somebody B. Take your time. At 25 we have already discussed, okay? And when I'm discussing all the chapter, and after that if you will mark a wrong answer, that is not a mistake, that is a blunder. ठीक है? Uterine artery ligation. Bimanual uterine compression. अच्छा. C is balloon tamponade. D is hysterectomy. So medical management failed. Okay, medical management is failed. After medical management, what is the next thing I mentioned? Why you are giving me a different answers? Abhi पढ़ के गए. Just now we studied. Sir, medical management failed. Sir, what is the next answer I will give? Mechanical compression. Sir, mechanical compression is done with the help of. Sir, balloon tamponades. So the next step is balloon tamponades. Is that clear? After medical management, we go with the mechanical compression. Okay? Balloon tamp. Artery, uske baad. Look, medical management, then you go with the balloon tamponade. After that, you go with the artery ligation, compression sutures and the artery ligation. After that, you go with the hysterectomy. Is that clear? Is that clear to everyone? Yes? Is that clear to everyone? So a case of postpartum hemorrhage is there. Uterine atony. Due to the atonic uterus, it does not respond to the uterine massage or the pharmacological treatment. Okay? And what is the next best step? Sir, I'm going with the balloon tamponades. I'm using Bakri's balloon having a capacity of 500 ml, or either I can use a Foley's catheter having a capacity of, Foley's catheter ki capacity 150. But in India, cheap condom catheters can be used. Sir, can you repeat it again? Remember, medical management is failed, you go with the mechanical compression. That is failed, you go with the surgical compression sutures. That is failed, artery ligation. That is failed, hysterectomy. Subtotal, total. Okay, sequence. Oxytocin is failed, methergin is failed, oxytocin is failed, carboprost, injectable drug, maximum doses 2 mg. That's why it's the most potent drug or the drug of choice for resistant all routine drugs. Is that clear? Is that clear to everyone? Yes. So let's have a quick recap of a postpartum hemorrhage. Okay, that completes your antepartum hemorrhage and the postpartum hemorrhage. Let's have a quick recap of a postpartum hemorrhage. I've discussed, we have just begun with blood loss in normal vaginal delivery more than 500 ml. Okay, then in cesarean section more than 1000 ml. If a patient is having a HB dropped by 1 gram percent, that is BPH case. If hematocrit decreased by 10%, that is a postpartum hemorrhage case. Is that clear to everyone? Followed by that, it can be mild, moderate and severe. Remember the main thing, the causes. We have 4 T's. What are the 4 T's? We have tone to trauma, tissue and thrombin deficiency. Tone is decreased due to the over distension of the uterus. What is the over distension of the uterus? That means a large uterus. What are the conditions having a large uterus? Now, first one is going to be your polyhydramnios. Second one is going to be your twin pregnancy. Third one is going to be your GDM, macrosomic baby. Fourth one is going to be your infection, chorioamnionitis. Is that clear? Is that clear? Then followed by that, we have a thrombin deficiency, ITP, VWD and hemophilias. Followed by that, we have a trauma, laceration, hematomas and a rupture, tear. Followed by that, tissue, retained placental bits. Remember the causes. Remember primary PPH, atonic uterus. After 24 hours, retained placental bits. Don't mark every time atonic uterus. Okay, you all are studying hard. Control your silly mistakes. Okay, is that clear? Then management, we are going to start with the prophylactic drug. What is the prophylactic drug? Oxytocin, 5 to 10 international units. The main drug, oxytocin, again 20 international units in the 500 ml of NS. Sir, why we are giving in the drip form? Because if we give bolus, what will happen? Sudden hypotension will occur. Kya hoga? Sudden hypotension will occur. Is that clear? Is that clear? Yes. Followed by that, we give methergin. Remember the contraindications of a drug, methergin. First one is going to be pregnancy induced hypertension. Second one is going to be your RH isoimmunization. Third one, a rheumatic heart disease or the heart disease in pregnancy. And the fourth one, before the delivery of the second twin. Is that clear? Followed by that, you give carboprost, PGF2 alpha, 0.25 mg, a 1 dose. Maximum 8 doses, that constitutes 2 mg. Is that clear? Followed by that, you go with the fresh frozen plasma and the artery ligation. Okay, artery ligation you will only do after what? Balloon tamponade and the compression sutures. If everything is failed, you go with the hysterectomy. Remember the order of the artery ligation: uterine artery, ovarian artery and internal iliac artery. Anterior or posterior? Sir, anterior branch. Sir, if we go for the posterior, what will happen? Patient will have a numbness in the lower limbs. What are the branches? Superior gluteal, iliolumbar, lateral sacral. And even if failed, you go with the hysterectomy. All clear? So that completes your APH and PPH. That completes your antepartum hemorrhage and postpartum hemorrhage. Anyone, any doubts? Yes? Chalo, let's move to the next question. A 28-year-old woman presents to the labor ward. A 28-year-old labor presents to the labor ward in an active labor and delivers a healthy baby vaginally. During the delivery of the placenta, there is a sudden onset of a profuse vaginal bleeding and the severe abdominal pain. The attending physician notes that the uterine fundus is not palpable. It's not palpable. On inspection, a fleshy mass is seen protruding from the vagina. What is the most likely diagnosis? What is your most likely diagnosis? So 28-year-old lady coming to you in an active labor. She delivers a healthy baby. During the delivery of the placenta, there is a sudden onset of profuse bleeding. Suddenly, bleeding came. Now patient is having a lower abdominal pain. The physician says that uterine fundus is not palpable abdominally. On inspection, fleshy mass is protruding from the vagina. What is the most likely diagnosis? So the most likely diagnosis, very good. So the most likely diagnosis is, very good, uterine inversion. So the most likely diagnosis is uterine inversion. So many hints are there. Okay, so many hints are there. So it's easy to catch it down. So the most likely diagnosis is uterine inversion. Now, what exactly is uterine inversion? The moment that the question mentions that there is a fleshy mass seen protruding from the vagina, what is that mass? That is your uterus. This is going to be the case of uterine inversion. What is the case, bacho? So this is a classical case of uterine inversion. This is a classical case of a uterine inversion. Now, what exactly is uterine inversion? Let's write what exactly is uterine inversion. Let's understand this chapter. So it means that there is a collapse of fundus into the uterine cavity, there is a collapse of fundus into the uterine cavity, or the prolapse of the fundus into the uterine cavity, or turning upside down of the uterus into the cavity. Is that turning upside down of the fundus into the cavity? That is going to be uterine inversion. So what is uterine prolapse? That is something else. Uterus is descending down because of the loose supports, ligaments are a lot looser, connective tissue disorders, abnormal conduct of the labor, abdominal pressure. That is something else. Okay, that I will teach you in the next part. What exactly is the Shaw's classification for the prolapse of the uterus? Okay, but here what is happening? Turning upside down of the uterus. Okay, turning upside down of the uterus. And whenever you are seeing that the patient is going immediately into the shock, that the patient is having sudden shock, suspect that this is a case of a uterine inversion. Okay, there can be two scenarios. If a patient says after the delivery goes into the shock, your answer is postpartum hemorrhage. But if a question mentions that a patient immediately goes into the shock, patient immediately sudden shock is there, suspect what? Suspect uterine inversion. But if the shock is out of proportion with a hypotension, hypoxia, now if a patient is coming to you after the delivery, patient is having hypoxia, patient is having hypoxia, patient is having hypotension or coagulation disorders, your answer is going to be amniotic fluid embolism. Because what is happening, these amniotic fluid contents, they go into the maternal circulation and causing the DIC or causing the collapse. That is an amniotic fluid embolism. Sir, should we treat inversion and then remove placenta or vice versa? First relax the uterus, पहले uterus को relax करो, उसके बाद take the placenta out. Okay, different people, different opinions, but it also depends. If my answer would be, it also depends upon the degree of a uterine inversion. Okay, then first don't try to remove the placenta. First relax the uterus and then remove the placenta. Give the drugs like nitroglycerin and the terbutaline. You relax the uterus, then take out the placenta. Is that clear? Is that clear? So now what is an etiology? If I talk about causes of the uterine inversion, first of all, I've already discussed that there is mismanaged third stage of labor. There is mismanaged third stage of labor. Okay, the third stage of the labor says that you should deliver this placenta with the help of a controlled contraction, or the Brand and Andrews method. So what is controlled contraction? You slowly try to remove this placenta from the uterus. Okay, but if I am doing sudden contraction, all of a sudden I'm pushing this cord, what will happen? Placenta will come out. Along with that, uterus will also come out. Along with that, what will happen? Uterus will also come out. That is called as uterine inversion. So mismanaged third stage of the labor or badly adherent placenta. Sir, what is this badly adherent placenta? This is a placenta accreta syndrome. Sir, what exactly is this? Due to the absence of a fibrinoid layer. There is an invasion of a trophoblastic tissue. in the myometrium or the serosa. Then we have a classical three types of adherent placentas. What are the placentas? We have increta, accreta and parcreta. So what exactly is this increta, accreta and parcreta? Now see, this is the normal placenta. Okay, now this is accreta. Over here there is a line. Okay, what is the layer? So this layer is a fibrinoid layer, and this fibrinoid layer is what? This fibrinoid layer is Nita Bush layer. And if this Nita Bush layer is absent, can you see this placenta is invading the myometrium? Okay, then it is invading more and going to the serosa or the pelvic structures. Now when I have to deliver this type of placenta, what is this type of placenta called as? Sir, it is called as adherent placenta. When I am trying to deliver these adherent placentas, what will happen? When I will try to remove the placenta, along with placenta, uterus bhi bahar aa jayega. That is why this adherent placentas are all the causes of. This adherent placenta is also the cause of what? It is also the cause of uterine inversion. What is adherent placenta? It can be increta, accreta and parcreta, depending upon this increta, accreta and parcreta, depending upon the invasion, depth of invasion. Is that clear? Depending upon the depth of invasion, it can be increta, accreta or parcreta. Now third cause, that it can be due to sudden cord traction. Rather going for control cord traction, you are trying to remove the placental cord. All of a sudden, what will happen? Placenta will come out along with the uterus as well. Then what to do first? So try to relax the uterus, push the uterus back normally, and then take the placenta. Is that clear? Push the back with the help of a maneuver called as Johnson's maneuver. Is that clear to everyone? Now remember, in case of an uterine inversion, patient goes into neurogenic shock. First, patient goes into neurogenic shock, followed by neurogenic shock, followed by hemorrhagic shock. Patient goes into the neurogenic shock followed by hemorrhagic shock. And if they ask most common cause of death, if they ask most common cause of death in uterine inversion, your answer is going to be hemorrhagic shock. 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 Is that clear? Is that clear to everyone? Your answer is going to be hemorrhagic shock. Is that clear to everyone? Now, so management. Now a patient is coming to you with a uterine inversion. There is an immediate shock. Okay, now management. First of all, resuscitation. Heavy bleeding. First of all, stable the patient. Resuscitation. Second, followed by that, you will do a manual reposition of uterus. Manual reposition of uterus. So this manual reposition of uterus, we are using a maneuver. What is the maneuver called as? Johnson's maneuver. The maneuver is called as Johnson's maneuver. Okay. Now remember, from the Johnson's maneuver, the part which comes down the first will go back in the last. Okay, you hold the uterus, okay, push it back with the manual hand. The maneuver is called as Johnson's maneuver. And the part which comes down the first, will go back the last, will go back to the last. Okay, followed by that, if the manual reposition fails, if it fails, you give uterine relaxant. You give uterine relaxant. What are the drugs you give? Nitroglycerin or terbutaline. You give the drugs like nitroglycerin and terbutaline. Okay, and then try again. We have a surgical methods as well. अगर उसके बाद भी fail हुआ, we have a surgical methods as well called as. We have a surgical methods as well called as Huntington surgery, called as Huntington and Haltian surgery. We have a surgeries, Huntington surgery and Haltian surgery. These are two different, Huntington surgery and Haltian surgery. We have one more method. Of pushing the uterus back. It is called as hydrostatic method, but it is not used anymore. Hydrostatic method. Okay, or it's called as hydrostatic reposition of the uterus. Hydrostatic reposition of the uterus. The method is called as O'Sullivan method. The method is called as O'Sullivan method, but does not use anymore. We don't use this method anymore. Is that clear? Is that clear? So what is a management? First of all, resuscitation, sir. Second is going to be your manual reposition of the uterus. If fails, you are giving the uterine relaxant, nitroglycerin. okay, and terbutaline, nitroglycerin and terbutaline. If again fail, try again. If again fails, sir, I'm going with the surgery, Huntington surgery and Haltian surgery. I'm going with the surgery, Huntington surgery and Haltian surgery. Is that clear? Now, first maneuver that we use is called as Johnson's maneuver. Is called as Johnson's maneuver. They can give the picture. The following maneuver is used for, okay, the following maneuver is used for. Your answer is going to be uterine inversion, uterine inversion. And remember, my dear students, that the part which comes down first, the part which comes down first, okay, will go back and last. The part which comes out first will go back in the last. The part which comes out first will go back in the last. That completes your next chapter, uterine inversion. That completes your next chapter, uterine inversion. Is that clear to everyone? Is that clear to everyone? Yes. O'Sullivan method, hydrostatic, it's outdated. Yes, we are not using that anymore. Chalo. Next one, answer the question now. Answer me the question, guys. What is the initial management of a uterine inversion? What is the initial management of uterine inversion? What is the initial management of uterine inversion? Very good. So first of all, I'm going from among the given options, I'm going with the manual reposition of the uterus. Now this manual reposition of the uterus, you are using the maneuver. क्या बोलते हैं उस maneuver को? Johnson's maneuver. Okay, Johnson's maneuver. Very good. Johnson's maneuver. Is that clear? Is that clear to everyone? Yes. So turning upside down of the fundus into the uterine cavity is a uterine inversion. Uterine inversion. Remember the three scenarios, bachcho. Patient after, let me write it here. Chalo. Right. Patient after delivery goes into shock. Your probable diagnosis is postpartum hemorrhage. If a question mentions patient after the delivery goes into the shock, your answer is going to be postpartum hemorrhage. If a question mentions that patient after delivery goes immediately into shock. Immediately into shock. What is your answer for that? This answer is going to be uterine inversion. The answer is going to be uterine inversion. So patient goes immediately into the shock, answer is going to be uterine inversion. Patient goes into the shock, answer is going to be postpartum hemorrhage. And if a patient goes into the inappropriate shock, or patient after delivery shock, along with that there is a triad of hypotension, hypoxia and coagulopathy. Hypotension, hypoxia and coagulopathy. Your answer is going to be amniotic fluid embolism. Your answer is going to be amniotic fluid embolism. Is that clear to everyone? So a patient, three scenarios: patient into the shock, PPH; patient immediately into the shock, uterine inversion; patient having hypotension, hypoxia and coagulopathy, amniotic fluid embolism. What is amniotic fluid embolism? There is an invasion of a maternal circulation. There is an invasion of a maternal circulation because of what? Amniotic fluid and its contents, leading to DIC. That is your amniotic fluid embolism. Okay, then you have other embolisms as well. You have studied fracture of a long bones is going to be your fat embolism. Deep sea divers, you have an ear embolism. Patient having deep venous thrombosis or the pelvic surgeries like total knee replacement surgery or the hip replacement surgery, that is going to be your pulmonary embolism. Okay, so remember those embolism as well. So that completes our 4 chapters: uterine inversion, placenta previa, abruptio placentae, vasa previa, and postpartum hemorrhage. All these 4 things are clear. Everything is clear so far? Everything is clear so far? Yes, all of you guys out there? Yes sir. So let's have a quick revision of these last 2 hours, whatever we studied. Sure. Okay, so we started our session with the first chapter, that was placenta previa. So what exactly is placenta previa? It's a placenta that is implanted partially or the completely in the lower segment. Okay, we have an old classification, Brownie's classification, that says that it can be lateral, marginal, incomplete, or central. What is lateral, sir? The placenta is in the lower segment but it does not reach up to the os. What is marginal? So the placental edge reaches the internal os. What's type 3? So placenta covers the internal os but close, but when it fully dilates, it does not close. Central, even if there is a fully dilatation, it exactly covers the full os. The clinical features, we have a painless bleeding. Remember that uterus is soft, non-tender. The size of the uterus is equal to the period of amenorrhea. It corresponds to that. Okay, the investigation of choice is going to be transvaginal scan, but for the screening you are doing transabdominal scan. After the diagnosing of the placenta previa, if it's more than 37 weeks, you are going with the cesarean section, and if it's less than 37 weeks, you are going with the expectant management. Okay, if a patient is hemodynamically stable, there is no active bleeding, there is fetal distress, no fetal distress. Okay, there is no fetal distress, then it is a suitable case for an expectant management. Okay, continue with no risk. Expectant management only do when there are no risk. What is the regime called as that we use? So that's going to be your McFay-Johnson's regime. So McFay-Johnson regime, you have to admit the patient, so arrange the blood. If RH negative, give anti-D and give steroids to the mother for the fetal lung maturity. I'm giving the steroids, beta-methasone and dexamethasone. 2 doses of beta, 4 of dexa, and check LS ratio, phosphatidylcholine, glycerol and all for the fetal lung maturity. Okay. Then coming the case of an abruptio placenta, when there is a premature separation of a normally implanted placenta due to the increased blood pressure and due to the trauma. The risk factors are the multiparous woman or the previous abruption. Remember these two mainly, hypertension and trauma. Clinical case examiner wahin se dega. There can be 2 types, concealed or revealed. So what is concealed? When the blood is not escaping out, it's within the membranes. What is revealed? Blood is escaping out, bleeding is there. Okay, then the presentation, first of all guys, remember the painful vaginal bleeding in the 3rd trimester. Usually the liquor is red stain and we usually see the dark red blood and the 3rd trimester. Due to the extravasation of blood into the uterine musculature, we have a bruised uterus called as covular uterus. The per abdominal examination, the uterus is tender and rigid, the fetal heart sound is not heard, fetal parts are not palpable, and the height of uterus is corresponding to the period of gestation. Okay, now we have a classification for this called as Page classification. Remember, grade 0 is asymptomatic, then 1, 2, 3 mild, moderate, severe. If a patient is having pain and bleeding and the fetal heart sound is normal, it's going to be grade 1. If a fetal distress is seen, fetal bradycardia is there, it's going to be grade 2. And if it is severe, that's going to be fetal death, maternal shock, or plus minus DIC. Now what is the management, sir? Sir, if there is distress or the hypoxia or fetal distress or fetal scalp pH less than 7.2, I go with the cesarean section. If not, I go with the normal vaginal delivery with the help of artificial rupture of membranes. So this artificial rupture of membranes will release the prostaglandins, cause the contraction and induce the labor. Remember, no cesarean section in abruptio placenta unless there is a distress or the maternal instability. Followed by that, if a filamentous cord is present on os, V for filamentous, or the bilobe suctionurate placenta is on the os, you're going to be a vasa previa. The presentation is a painless bleeding, and due to the fetal blood loss, baby will have a fetal distress, but there is no uterine tenderness. This mimics with the placenta previa, my dear students, but yes, if a filamentous insertion and fetal blood loss, that is a vasa previa. Okay. Diagnosis, you check the TVS with a color Doppler and you check the vessels. App test, you do. The fetal red cells are resistant to the alkaline denaturation, so the blood stays red. It's a fetal origin. If it's colorless, it's a maternal origin. The management is what? Cesarean section. You cannot go for the expected management, or you cannot go for the normal vaginal delivery, because once you do, the rupture of these vessels will cause more bleeding. Patient is already having a blood loss. It will worse the condition. Next, we discuss about PPH. You already know 4 T's: tone, trauma, tissue, and thrombin deficiency. Followed by that, remember, tone is decreased due to the large uterus. The conditions: poly, Tiven, microsomic chorioamnionites. The thrombin deficiency, you have ITP, VWD, and hemophilias. Trauma, you have lacerations, perineal tear, hematomas, and tissue, you have retained placental beds. Then the primary, within 24 hours, atonic uterus can be the most common cause. Secondary, more than 24 hours, the retained placenta beds is the most common cause. Upon abdominal examination, uterus is palpable. Trauma hua hai, traumatic PPH. On examination, uterus is not palpable, that's going to be your atonic PPH. Drug of choice for prophylaxis as per AMTSL is oxytocin 5 to 10 international units. Main drug of choice is oxytocin 20 international units in the 500 ml of NS. No bolus because it can cause a sudden hypotension. Second is going to be methergin with a 0.2 mg intramuscular route. Remember the contraindications: PIH, heart disease, RH isoimmunization, and before the delivery of the second twin. Followed by that, we give misoprostol, but yes, when the drug PPH is resistant to the routine drugs, you go with the injectable drug, injection carboprost. Dose is 0.25 mg, maximum 8 doses, 2 mg can be the maximum dose. Followed by that, you will transo, fresh frozen plasma, and the mechanical compression with the help of a balloon tamponades. What are the balloon tamponades we use? Buckley's balloon 500 ml of NS, Foley's catheter 150 ml is a capacity. And once the bleeding is stopped, you remove these tamponades after 12 hours. Surgical methods, you're going with the compression sutures. The most common that we use is going to be your Bilin suture. And this Bilin suture, when you ligate, when you compress the suture from anteriorly and the posteriorly, the main principle is they should meet at one point so that they compress the suture and compress the uterus and stop the bleeding. We have other sutures as well, like Heyman, Co-square, and Gunshell sutures. Then you will, even if the bleeding is not stopped, you go with the artery ligations like uterine artery, ovarian artery, and the internal iliac artery. Which branch? Anterior branch will ligate. If you ligate the posterior branch, what will happen? Patient will complain of a numbness in the lower limbs. What are the branches? Superior gluteal, iliolumbar, and lateral sacral. And if not, you go with the hysterectomy, subtotal hysterectomy, take the uterus only out, and if not, take the uterus plus cervix both out. Okay. First drug to given in PPH, oxytocin. Prophylaxis ही start oxytocin से होता है. Is that clear? And then uterine inversion, collapse of the fundus into the uterine cavity due to the mismanaged third stage of the labor, due to the badly adherent placenta or the sudden contraction. The part which will come out the first will go back in the last with the manual reposition. First of all, resuscitate the patient, then the manual reposition of the uterus with the help of a Johnson's maneuver. Okay, then if fails, you need to relax the uterus with the help of a nitroglycerine and the terbutaline, and then try again. If it again fails, you go with the surgery called as Huntington surgery and Haltian. Sir, अब वो क्या होता है उतना deep नहीं जाना at this level. Just remember the procedures, abdominal procedures, Huntington's and Haltian. Okay, one more outdated method, that's going to be your hydrostatic method. With the full pressure, you give the normal saline or the water in the uterus and it pushes it back, what called as hydrostatic method or the O'Sullivan method, but it is outdated. This completes your 3-4 chapters for today. I hope guys you have a good revision. Okay, and remember this as well: patient after delivery goes into shock PPH, immediately is uterine inversion, hypoxia, coagulopathy, and hypotension tried, amniotic fluid embolism. That completes the session of the day. Is that clear? If you have any doubts, you can ask, you can ping me on the Telegram. Your texts should be only related to the doubts, okay? So I can get back to you guys, okay? So keep revising. We are coming closer to the exams. We are having coming up subjects. I'll be taking the pathology, PSM and pediatric sessions as well. So yes, and meanwhile, if time is there, we will be able to take also OB-GYN part 2 as well. Regularly classes, main batches are done yet, so let's see. Telegram, you can get the links on the Telegram with the FMG with Dr. Talib Bilal. You can join, and rest MEDUHUB channel as well, you can get over there as well. Is that clear? All done, guys? All clear? Part 2, yes, part 2 will be coming for sure. Let's see. In the part 2, we'll discuss mainly the labor chapter, or we go with this gynecological important chapters. Then followed by that, first let's complete the PSM, then we'll see. Is that clear? So keep revising. Watch the session once more at 2x speed, and so that you can crack it down. Okay, remember all the things. OB-GYN is a scoring subject. I hope the session was good enough. Keep solving questions, keep revising. We are closer and we got this. Okay, thank you all being interactive. Thanks.